Good day, everybody. Welcome to this webinar on understanding and managing sleep for young children with fetal alcohol spectrum disorder. My name is Marlene Dray, and I'm the FASD Prevention Program Coordinator, one of two, at the Saskatchewan Prevention Institute. And I'm so very pleased to be hosting this webinar today. This webinar is a partnership between the Canada FASD Research Network, known as CanFASD, and the Saskatchewan Prevention Institute. The Canada FASD Research Network is the only national FASD research network in Canada. They work hard to build evidence through their research that will be meaningful to individuals with FASD, their families, and their communities. You can check out their website at www.canfast.ca, or you can follow them on Facebook, Twitter, or LinkedIn to stay up to date on the most current information. At the Saskatchewan Prevention Institute, our goal is healthy children. Our mission is to reduce the occurrence of disabling conditions using primary prevention methods. The Saskatchewan Prevention Institute believes that children of all abilities have the right to the best physical, social, and emotional health possible. We share evidence-based information through print and web-based resources, education, and training throughout the province of Saskatchewan. Programs include child injury prevention, early childhood mental health, FASD prevention, maternal and infant health, parenting programs, and sexual and reproductive health. You can learn more at our website, www.skprevention.ca, Facebook, Twitter, and LinkedIn. I am speaking today from Treaty 6 territory and the homeland of the Métis people in Saskatoon, Saskatchewan. And now it's my pleasure to introduce Dr. Hanlon-Dearman. And first, I just want to give a little bit of an introduction. Dr. Anna Hanlon-Dearman is a developmental pediatrician and medical director of the Manitoba FASD Center in Winnipeg. As a developmental pediatrician, she treats children with cognitive, learning, and behavioral disabilities. This includes children diagnosed with disabilities such as fetal alcohol spectrum disorder, ADHD, and autism. Autism spectrum disorder as well. Oops, I said that. Okay, she's an associate professor of pediatrics and child health with the University of Manitoba and holds a cross appointment with the Department of Community Health Sciences. She is also a research co-lead with Canada FASD Research Network in the area of FASD diagnostics, and she shares this with her other co-leads, Dr. Mansfield-Mela from Saskatchewan and Dr. Jocelyn Cook. She has been awarded the Manitoba FASD Research Scientist Award from Healthy Child Manitoba Office with the University of Manitoba Community Health Sciences, and she chairs the research group at the Manitoba FASD Center. Dr. Hanlon-Dearman has been working collaboratively with a number of research teams to understand population health issues of individuals with FASD and to better integrate care for impacted individuals and their families. Her clinical and research interests include neurodevelopmental patterns of children with FASD, as well as children with a variety of other neurodevelopmental disabilities. I have heard her present before, and I know you are going to enjoy this presentation and learn a lot. And now I'm going to turn everything over to Dr. Anna Hanlon-Dearman. Thank you.
Thanks, Marlene, and I'm delighted to be here. I'm just going to share my screen here with you. And as I'm sharing the screen, I want to acknowledge with gratitude and respect the land that I'm existing on right now, which is Treaty 1 territory, which is territory of the Cree, Anishinaabe, and Métis people here in Manitoba. And I'd invite all of you to think about with gratitude and respect the lands that you come from and are currently on. Now, so I'm going to be talking a little bit here. I have no conflicts of interest to declare, but I will mention that a couple of things. It's been mentioned that I am a co-diagnostic lead with CanFASD. I'm also a co-investigator on one of the national programs run by Penny Corkum and her group, which is Better Days, Better Nights, and they do have a current program right now for children with developmental disabilities, which includes FASD. This is where I work. It's a cookie factory, the Mr. Christie's Biscuits building. It's been renovated inside, and we are quite enjoying it. We have a network throughout Manitoba. We have seen well over 4,000 children. We've diagnosed over 2,000 children in the over 20 years that we've been functioning as a clinic. So we've had quite a bit of experience. We're venturing into adult diagnosis now as well. And so we're really, we've seen lots of kids with lots of different difficulties. And certainly sleep is one of those difficulties that, it exists no matter what age group that we look at. I'm going to focus my comments today primarily on preschoolers because that's my love and area of interest. There's going to be parts of this presentation that'll be a little bit scientific heavy in terms of some of the biology of sleep of children with FASD, and I think it's important to look at that because really sleep isn't just a behavior, there's a biology to it. So we have to think about that when we introduce both behavioral as well as sometimes medication treatments. I will talk about what general sleep needs are and how we can all help our children sleep, because that's what this is really about. So this is a really typical consult that I get. It's really, asking me to see a child with FASD who's having poor sleep, family's exhausted, everybody's struggling. What can they do? And sometimes, a typical example might be a 3-year-old. He may have had prenatal alcohol exposure with or without confirmation of fetal alcohol spectrum disorder. I'm frequently told he's been restless and disrupted since birth in terms of his sleep. I may have a single parent that I'm seeing. They may be living in side-by-side kind of row type housing. There may be supportive families and neighbors. He may have other family members that he sees irregularly on the weekend. There may be different schedules. Sometimes he may be going to sleep late because mom is working to support the family. But no matter when he goes to sleep, it's often taking a long time to fall asleep. The schedules are challenging. There may be times where mom is letting him fall asleep in the front of the TV, and then he gets transferred to his room. But even in his room, he may be rocking or chewing bedclothes. He may be waking suddenly at night with these screaming behaviors that are just really challenging to settle. And it may be really challenging for the parent because she may be afraid that the neighbors will call and be upset about this. And boy, he's really busy during the day, really dysregulated. So there's lots in the stories that I'm told. And if I were to talk to you about him when he was older, you might hear that he's still frequently tired. He's struggling to concentrate. Now he may have started a medication for ADHD. He may be still rocking himself. Maybe he's chewing on his sheets. Maybe he's doing some other sensory behaviors. And by the time he's an adolescent, he's maybe up late at night playing video games. He may have started using marijuana to help him sleep or relax. So there's persistent challenges that just really grow with him through the lifespan. I venture into using different pronouns. You could substitute the pronouns ad lib because it really doesn't matter whether we're talking about male or female children, male or female parents. The challenges are persistent. So I hope you all know who are joining me that FASD is complicated. It is a neurodevelopmental challenge, a disorder that has a range of impairments that really affect the whole brain and body. And the more we do our work, the more we understand that and the better we understand that. And the effects are really dependent on all kinds of things. When there was exposure, how much, but it's also really dependent on things like the genetics of that particular individual and whether there were other exposures, what the environment might be like. But it's important to remember that sleep is equally complex, that it's equally neurodevelopmental in nature, and it's also an integrative process. So it's really what brings things together. When we're resting at night, our eyes and our body may be resting, but inside our brain is still working to put things together, pull memories together, pull learning together. And it really helps us pull those processes that help us regulate ourselves during the day together. There's a range of sleep that's normal. If you asked 100 adults, you'd get lots of different answers. And there's also a range of challenges with sleep that are related to our biology, but also to our environment. It's really important for healthy physical and cognitive development. Sleep all by itself, whether we're talking about FASD or not FASD, it's so important in how we learn, how our executive functioning progresses, our attention, our creativity, but it's also important to our mental health, how we regulate our mood and our behavior, anxiety and depression, how we manage stress, our performance day to day. Anybody who's been up all night for whatever reason knows that your performance day to day is affected by that. Can also affect our immune function. There's lots of good evidence on that. It can affect growth. It can affect our weight. It can affect the development of chronic illness. And nowadays, in the days of COVID, you know, when life has changed so quickly and our schedules have changed so much, sleep is a really critical part, sometimes to the betterment and sometimes not to the betterment. So here's where I'm going to be just a little bit dense briefly, so I hope you'll all bear with me. There is a quick sleep primer here that I want you to be aware of. Sleep is neurologically mediated, and this article in Nature, which is usually a pretty dense journal, has some really nice, easy to understand graphics that really emphasize a couple of things. One is there's sleep signaling that goes on in our brain. There's sleep signaling, which is one pathway. There's wake signaling, which is a different pathway, and they have to work together. They come from the deeper parts of our brain, really right in the middle there. We call those the brain stem, our hypothalamic nuclei. And there's gatekeeping systems that kind of flip between our waking and our sleeping. And it involves neurotransmitters, it involves neuronal transmission systems, and it regulates not only sleep and wake signals, but it really regulates our arousal systems. Because in order to sleep, we have to dampen down arousal, and in order to be awake, we have to let arousal happen. So in short, there are multiple systems that are involved, that are really involved from a brainstem pathway. And when we talk about FASD a little bit later, and we talk about maybe some of the impacts of prenatal alcohol on that HPA axis, we're also talking about systems that are involved in sleep and wake. We have a cycle of sleep and wake that starts when we start waking up in the morning, if you want to start there, and goes throughout our day. So we have drives that, on the one hand, if you look at the bottom of my picture there, which is not my picture, a picture from this particular article, there's a waking drive that happens during the day. Hopefully we're at our most alert first thing in the morning. And as we do things during the day, a variety of things, as we exercise, as we learn, as we eat and drink caffeine, for example, we have moments of greater alertness, or perhaps as the day goes on and we go into our afternoon and we have that afternoon slump, we may start to feel some slipping of our wake system and some increasing of our sleep system, so that hopefully by nighttime, we're feeling more drowsy, more ready for bed, and we can enter into more sleep processes. So we have this balance, and if you will, kind of a teeter-totter of wake systems and sleep systems. We also have what's called our sleep cycle, or our sleep architecture. And you may have heard of non-REM sleep and REM sleep. REM sleep is what we think of as our dreaming sleep, and non-REM sleep are those stages before our REM sleep that we go through in cycles throughout the day, so in waves throughout the night. And we go through our non-REM 1, which is kind of like dozing on the couch. Non-REM sleep stage 2 is when we really can see on our EEG, if we were to have sort of a brainwave test, we'd really see evidence of sleep. like sleep spindles and things. We're no longer kind of aware of our environment. And stage 3 is the deeper sleep. That's when we're really solidly asleep. We may be difficult to arouse. REM sleep is when our body really stops moving and we start to have dreaming. That's when you see the eyeballs kind of moving around in sleep. But it's also when we have learning and memory consolidation. And those things, even though it looks like a pattern that's just sort of 1, 2, 3 in REM, it happens in waves throughout the night. So we go through these periodically. So different behaviors are associated with different stages of sleep. And that's what we call our sleep architecture. I'll talk about that a little bit later. Insomnia has all kinds of different definitions and descriptors, but basically one of the descriptors that I like is really thinking about hyperarousal of systems that are really meant to be sleep inducing and wake inducing. And when we're hyperaroused, we have an imbalance of those sleep wake systems. And all of these systems kind of interact and overlap a little bit. And so, sorry, I think I didn't put in a slide that I was thinking about. But if you remember, I was talking about a teeter-totter. You're supposed to have a nice balance between this. And there are some theories that say we either have insomnia because we sort of err towards more the waking when we should be sleeping. But there are other theories that say we kind of teeter off and on in different ways. So we may be more wakeful when we should be sleeping at various times of the night. So I don't think there's any one system that's been solidly proven, but I think it's relevant to FASD because when we think of some of the mechanisms of how alcohol affects brain development, it's one of those mechanisms is kind of patchy. It has to do with neuronal migration. So we may have different individuals experiencing sleep in different ways. So this is a slide that isn't specific to FASD, comes from the States, the National Sleep Foundation, and it's a really nice slide showing how much sleep we need overnight, over our lifespan from newborn to adulthood. And it shows a couple of things. One is it shows, if you look at the dark blue bands in the middle there, that's kind of what we'd call the average recommended amount of sleep right from newborn to adult. And you'll see that there's a range for every different age. So for example, newborns are sleeping a lot, 14 to 17 hours during that 24-hour period. But if you're talking about, say, a toddler, a 1 to 2-year-old, that's maybe 11 or 14 hours during the 24-hour period. And then you'll see young adult and adulthood at the other end. The other important thing on this slide is to recognize that there's quite a wide range. The range tightens as you get a little bit older, but for infants, toddlers, and preschool, it can be as little as 10 hours if you look at the infant, or as much as 18 hours at any different age. So even when we're talking about kids with FASD who are probably on the shorter end of any of those ranges, even kids without FASD may have different ranges of sleep. Typically, I think it's fair to say that kids with FASD tend to be short sleepers. Does it matter? Sure, sleep matters. It matters because it impacts our functioning. It matters because we may have poorer developmental outcomes if our sleep is poorer. But the interesting thing is some kids may be less resilient to insufficient sleep. And kids with FASD may be some of those kids. And it's something we can do something about. If we can improve sleep, maybe we can improve functioning and improve later developmental outcomes. I think I'll skip this slide because I think we talked about that a little bit and I want to move on a bit. So sleep in FASD is super common. Depending on the research you look at, probably up to 85% of kids with FASD may be having difficulty with sleep. That's most kids. And that is in keeping with sleep difficulties in kids who have other kinds of developmental disabilities, intellectual disabilities, autism. It's a very, very common thing. And if a primary care provider is not asked about sleep, they need to be asking about sleep. It's complicated. They usually have shorter sleep patterns. They usually have more frequent night awakenings. So remember, I talked about teeter-totters and having problems with hyperarousal through the night. That's what I'm talking about here. They may have more parasomnias. Parasomnias are those behaviors in the middle of the night that look like, depending on which age we're talking about, they can look like things like night terrors, confusional arousals, teeth grinding in the middle of the night, sleepwalking, sleep talking. All of those things can be more common in kids with FASD. And interestingly, a couple of articles, the first one's one that I led, and the second one is one of my colleagues in the States, more frequent sleep anxiety. And this is talking about sleep anxiety that is separate from anxiety that may be related to, you know, for example, kids in care who may have disrupted placements or disrupted attachment. Separate from that, it's something else entirely. We know that prenatal alcohol disrupts those integrative neurologic processes. So if sleep on the one hand is one of those processes that helps us integrate our cognitive behavioral processes, prenatal alcohol disrupts that. And we know it disrupts it through reducing the things that make us inhibit behavior appropriately, making us more impulsive, disrupting the way we pay attention, disrupting how we pull our learning together, but also some of the aspects of sensory integration and regulation of arousal. The risk factors for sleeplessness are in every area: physical, whole body risk factors, sensory differences, behavior, learning, impaired communication. And then it's really important to think about sleep in the family and community context, and especially in these days of COVID and lockdowns. We really have to think about sleep not just in the individual, but what does it mean in an era of lockdowns to be sleeping, especially for people who may be in more isolated communities, and how can we help them? When we're talking about preschoolers, it's important to think about fatigue a little bit differently than we do in older kids. In older kids and adolescents, we think about fatigue much like we do in adults, looking tired, being more perhaps aggressive or irritable. Little kids, sometimes when they're tired, they get more hyperactive, they get more disorganized, they can certainly be more irritable, but they can also be more sensitive to all of those sensory symptoms, whether it's more sensitive to the tactile symptoms or to the sound, to touch, to textures of food impacting their feeding. They're just more sensitive to everything. And the things that we usually do that usually help sometimes just don't seem to work as well. And so when we see that, sometimes we have to think about, is this a function of they're tired? Again, not to sort of get too technical in terms of some of the sleep literature, but the sleep literature goes way back. It goes to back to the mid-'80s when they're doing rat models of sleep, when they're looking at sleep in newborns who have been alcohol affected in the nursery. And they could, you know, there was some really interesting stuff that was done in the 80s where they did research in a lot blunter ways than we do nowadays, where they went into the nurseries and they simply asked moms, like, how much did you use in terms of alcohol when you were pregnant? And moms were pretty bluntly giving them their amounts because there were different sensitivities perhaps at the time. And so they were really able to correlate sleep and amount of alcohol used, and they could find out that even newborn babies in the NICU, in the neonatal nurseries, were having trouble regulating themselves, regulating their temperature, their feeding, their sleep. They had shorter REM periods even in the newborn nurseries. They had disrupted sleep architecture. They could tell that it was impacting their neurotransmitters. And a little bit later on down the road, they could show that the heavy use of alcohol was more related to fragmented slow wave sleep and memory impairment. So all of this could be demonstrated over like 20 years. People know this. They not only know that, but they were able to show that those early changes in babies in the nursery could be correlated later when they were doing developmental assessments to motor and cognitive development. So it wasn't just the alcohol. The alcohol was playing a role for sure, but also the fact that they weren't sleeping well was impacting them. And there's some research that's being shown by a colleague in the States that shows those early exposures and that early sleep deprivation can be shown even as late as adults. So this is something that's carried with them. It's very interesting research. So this is basically some of the stuff that we did. And if you look at the CSHQ, it's the Children's Sleep Habits Questionnaire. So it's basically a questionnaire that we do with parents. And we compared it to kids with FASD and kids without FASD. So the kids with FASD are the kids in red. And what parents were telling us is some of this is not too surprising, and some of it is. One is if you look at bedtime resistance, the kids were having more bedtime resistance. These are preschoolers. They actually were going to bed in terms of sleep onset. Surprisingly, they were falling asleep often at not too much different compared to control groups, but they were much shorter sleeper. They were showing more sleep anxiety, more night wakenings. And one of the interesting things that at this time was fairly new was showing more of those parasomnias. So they were chewing, biting, night terrors. You know, we did along with this, and I'm not going to show some of those data, but we asked parents to describe some of those parasomnias. And I had one mom describing how a kid was chewing through right to the springs of the mattress because they were chewing so hard on their mattress. And I had another kid who was sleeping with a tennis racket, one of those old style metal tennis rackets, and chewing through the outside band of the tennis racket right through to the strings. And he was only around 3.5. So really significant oral sensory behaviors. The oral sensory stuff surprised us a little bit. We looked at sleep disordered breathing because that's what all the sleep clinics like to look at. So when you're, if you ever have kids that are being sent to sleep clinics, the primary thing that a sleep clinic is looking at is sleep disordered breathing. I'm actually going to show that in the next slide, I think, because this was one of my colleagues in the States. They do look at sleep disordered breathing, but most of the kids aren't showing sleep disordered breathing, or if they do show it, it's mild. Most of the kids are showing fragmented sleep architecture, not related to sleep disordered breathing. So you should think about it, especially if you have a kid who's snoring, but it's mostly not that. I put the picture up in the corner because if any of you are caring for kids with FASD, and if any of your children have more sensory symptoms than typical, I want you to imagine taking your kid to the sleep lab, which if they need it, they should have it. But imagine taking to the sleep lab and imagine having all of those stickies attached to their forehead, to their temples, to their cheeks, their chins, their fingers, their feet, their chests. And imagine if you'll get a typical night's sleep on that one night overnight in the sleep lab. It's a good thing to do if you have a kid who's snoring significantly or is pausing in their sleep. But if not, I think you need to go a different direction in assessment. The interesting thing about what our colleagues in Ontario, Sherry Gorel, showed is that if you look at melatonin, dim light melatonin onset, that's the DLMO, if you look at that, and it's a really complicated thing to look at, you have to sort of take blood every hour overnight. So take that little child with all those stickies and just take blood from them every hour overnight. Not an easy thing to do. But if you can do that, what she showed is 80% of those kids have an abnormal melatonin profile overnight. So what you need to see is as the lights go off, we secrete more melatonin. And then over the course of the night, your melatonin sort of starts to decrease because you're preparing to be awake. Remember that 85% of these kids have sleep problems. If 80% of them have an abnormal melatonin profile, I think that tells us something important. I'm very interested in the sensory physiology. I'm not going to bore you with lots of details about it, but I wanted to put in one slide that tells you sensory-based behaviors in children with FASD, as well as kids without FASD, they're neurologically mediated. There are tracts and neurotransmitters that regulate our sensory behavior, and a lot of those tracts are in our white matter. So the gray matter is kind of, all those curly stuff in the brain there. The gray matter is the outside part. The white matter is the stuff that connects the gray matter to those deeper structures in the brain. And if I were to tell you that prenatal alcohol disrupts that white matter integrity, then what I'm telling you is that prenatal alcohol is disrupting the communication between those deep tracts that regulate our neurotransmitters and the thinking tracts that are on the outside parts of the brain. And those are also involved in our sensory regulation. When you see sensory-based behavior in your kids, you're seeing a real behavior that's neurologically mediated. Enough on that. We also showed that all of those behaviors I showed you in that blue and red graph are related to various sensory behaviors during the day. Every kid is different, so there's no one pattern here that you're looking for. You're just looking for more sensory reactivity. So if you take all of that biology of prenatal alcohol exposure and sleep biology, and then you add it to an environment that may have been affected by prenatal stress, prenatal malnutrition, all of that also impacts your circadian rhythm, your day-to-day rhythm. If you add in maybe a family history of mood disorder, if you add in other stressors, you're increasing the likelihood of sleep disruption. And interestingly, there's a bunch of other research that says maternal prenatal mood disorder, moms who have anxiety, depression, that can also predict poor sleep in toddlers on top of things. It's no one thing that contributes to sleep, but the more of these things you have, just like the more of those adverse childhood experiences you have, the more likely you are to have an additive effect upon your sleep and disrupted sleep. So here I'm also saying that when you have all of those things happening, you have attachment disruption, you have kids who may have been in multiple placements in foster care, all of those environmental scenarios, we have an overrepresentation of kids with prenatal alcohol exposure and FASD. And the result is we have a lot of challenges implementing practices of sleep hygiene, which I'm going to talk about. And we have more frustration in terms of parents who are trying to do the best that they can in terms of helping kids fall asleep. So physiologic changes I talked about. Could there be lasting implications for health, for overall health and daytime functioning? For sure. And could there be an impact on parent-child relationships and this impression of a difficult sleeper who may have difficult behaviors during the day? Absolutely. But the good news is there are things that we can do to help here. When we support sleep, we support the parenting relationship, we support the environment, we support the child, we can reduce costs to society, and we can impact the physical health of parents and children. And I've put a few references there, but there are lots of references there. And so we do have some opportunities to maximize positive functioning here and reduce secondary problems related to this. The model I always take clinically is kind of a multidisciplinary and multisensory model that looks at what we can do to regulate sleep and sleep patterns, what we can do to address sensory disruption, what we can do to directly impact sleep, and what we can do to impact the environment and parental sleep. So it's really important to think of a little bit of everything. So in the last few minutes of my talk, I want to talk about briefly treating. The first slide I really want to do is emphasize that the goal that I take is to reduce the burden of care. We may need to address multiple areas of at once. What we do is not necessarily related to what you may read in all of the well-meaning books out there, but may extract things from some of those books. We have to take special care for children who have a history of trauma, children who may be in and out of the hospital, for example, if they have cardiac problems, kids who may be newly adopted or newly in care. Sometimes we may do things differently for those kids than what you may see in typical recommendations. A team approach is really important if you have access to a team. If you don't have access to a team, you can still do a lot by doing the best you can with the people in your circle of care who can become informed on this. It's really important to have a developmental evaluation in young kids so that you really know what their strengths and weaknesses are, including their cognitive profile, including their communication profile. And it's really important to really understand the environment. I've been doing a lot of consultation virtually in these days of virtual care. And I have to say that it's been tremendously informative, not just because in many ways it can be easier for families, not always, sometimes it's harder, but also because it really gives insight into the environment that the families are experiencing in a way that you don't get when you're seeing kids in your own clinic. Sleep hygiene, while the principles remain the same, needs to be individualized, and that's where the consultation comes in. And yes, we may use melatonin and very selectively other medications when we're talking about preschoolers. So I think this probably says the same thing. Very briefly, actually, I'm going to go back to that. The general principles are sleep hygiene, but when we're talking about managing sensory and circadian rhythm, I always send families home with a sleep log, and it's always a 2-week sleep log, and it's an hour-to-hour, day-to-day look at what does sleep mean. It is a lot of work for families to do these, but it's tremendously informative, and it's far more informative for me when I'm really looking at how do I impact and individualize the recommendations around sleep hygiene that I'm going to be making. When we're managing sleep, it's different depending on what we're talking about. If a child's having difficulty falling asleep, which is common, there are different things that I'm going to be managing in terms of their circadian rhythm, their self-regulation, and I've done a little bit of a focus on medications in there, or in terms of managing anxiety or behavior before they fall asleep. And it's somewhat different than if I'm talking about difficulty staying asleep, where we're really talking about the self-regulation of the individual in the context of their environment, their behavior, possibly some medications, but maybe not necessarily. Maybe we're looking at restless legs in a small proportion of kids, but maybe we're also looking at nutrition and iron stores. If we're talking about a kid who has early morning awakening, I may be really looking at that circadian pattern, looking at the amount of hours they need over the course of a night, and really talking with families about how do we adjust those hours and maybe shift their cycle a little bit forward. We may in fact be talking about a kid with a decreased sleep need. You can see that we really need to tease this apart and look at that sleep log in a really specific kind of way. It's really important to think about the circadian rhythm, and that's way back when that we were talking about the architecture, because there's a biology to that rhythm that is linked to melatonin, and we may need to use melatonin. It's really important to use melatonin appropriately. Very frequently, I see melatonin not being used appropriately. People using melatonin, for example, as needed, PRN, one day they use it and one day they don't. That's an inappropriate use of melatonin in my view. For preschoolers, using exceedingly high doses of melatonin is an inappropriate use of melatonin. I think that if you're using really high doses of melatonin, it's really important to go back to basics, back to a sleep log, and say, what are we really treating when we're treating melatonin? Remember, I talked about, are we treating a circadian problem? Are we treating a challenging a challenge with anxiety, are we treating difficulty falling asleep because of breathing or nutrition? It's really important to know exactly what you're treating, because not all of those things should be treated with melatonin. And if you ever have somebody who says, you know, I've tried melatonin, it doesn't work, I would really tease that apart and look and see, is melatonin being used to treat the right problem? It's really important to look at day-night regulation. There's a very smart author who's an occupational therapist in the States who says a good night's sleep begins first thing in the morning. And that's about looking at what are our patterns during the day, when do we regulate activity during the day, when do we regulate our food intake during the day, when do we regulate our physical exercise during the day. Here we go. It's really important to have a very good schedule. If you don't have a sleep problem, then your schedule is probably working for you and you don't have to worry about this. However, if your child does have a sleep problem, then I look at this in quite a bit of detail, both daytime and nighttime. We may be looking in as much detail as when are the movement breaks, when are the snacks, when do you use those sensory behaviors, when are you awake, when are you asleep? So it's not just the bedtime routine. When do you get your light in the morning, and how late does that light continue in the nighttime? The Canadian Pediatric Society has some information on sleep, and it's a good starting place. But again, it really needs to be teased through. The participation also actually has some really nice recommendations in terms of how much activity, physical activity, a child should get, including preschoolers, during the day. And if I were to tell you preschoolers should be getting 180 minutes of aerobic physical activity every single day, then you really need to look at the day. And when your kid is having the opportunity to move around. For any of you who feel like that's a lot of movement in a day and worry like, how the heck am I going to do that? Let me reassure you that everything counts. Preschoolers run around during the day, even in the house, and every lap they do from the kitchen to the living room counts. Sleep hygiene principles are based in science and behavior, so don't dismiss them too quickly. The important part about sleep hygiene is individualizing what we are talking about. So very quickly, I'm going to review them. They can be used with a visual schedule. I've used some board maker symbols here. I've pulled it from the Autism Speaks website because many of these schedules can be very applicable, but it's really, really, really important to establish a bedtime routine insofar as whatever works for you and your family. Avoiding big meals close to bedtime, avoiding things like Coke or caffeinated teas, having a comfortable, cool bedroom, no TV or media in the bedroom, and we can do a lot of talking about that. There are also some really nice websites that regulate and provide recommendations for media hours for preschoolers, which is short, in short. We talked about exercise, so here's a nice little demonstration about from actually the PBS website, the TV, ironically, public broadcasting in the States, that really links our melatonin level with what happens during the day. And so it's a really nice reminder that what we do in the day impacts what happens at night. Having an emotionally stable and positive tone in the evening sounds really hopefully natural and logical, but that goes for your media. It goes for what may be being heard. It's important to also think about transition objects. It's important to review medications. If your child has asthma and is on a Ventolin puffer, that is a stimulant at nighttime. So everything counts here. Whoops, hang on there. Sensory strategies are super important, and if your child has an occupational therapist, they'll know exactly what I'm meaning here. They can talk about these sensory strategies with you. These are not a comprehensive list of strategies, just a few examples in a variety of areas that you can think about. Every kid is different. You should be looking at sensory strategies in an individualized way with the child and reviewing that based on some assessment of sensory processing with your occupational therapist. implement these in a way that makes sense for your child. If some of these aren't applicable, don't do them. This is truly very individualized. I'm gonna skip that. It's also really, really important to think about sleep support for parents and caregivers. Coffee first, talk later is often the important theme, but parents' sleep patterns in the literature are linked to children's sleep patterns, and you really have to work on ensuring that parents are also sleeping well, to make sure that kids are also sleeping well. To also think about parental screen time, and what, not only in terms of what kids may be exposed to, but what's being modeled in a household, and really in terms of parental screen time and how that impacts the parent-child relationship, and what our parents are using to cope, both functional and dysfunctional patterns. Really, really important to talk about. Penny Corkum, who is I referenced way at the beginning, who runs the Corkum Labs in terms of sleep in Halifax, and who is leading the Better Nights, Better Days for children with neurodevelopmental disabilities. She talks about the ABCs of sleeping. I've put them out here, and it's really a way of thinking about the sleep in terms of what is age appropriate, what the bedtime routines are, what the consistency is, scheduling, location for sleep, electronics, exercise, positivity, independence, needs, and hopefully leading to a great sleep. So it's a nice little thing you can think about when you're thinking of ABCs and sleep. Treatment recommendations specific to kids with FASD. First of all, get a really good comprehensive multidisciplinary assessment, because that assessment is going to inform the types of strategies you're going to individualize for your child. If you can get a diagnosis, that's important, but if you can really get that comprehensive multidisciplinary assessment, that's what you're going to use to inform the strategies you're going to use. It's really important to advocate for healthy families in the context of the child as well, to apply those principles of sleep hygiene in a comprehensive management plan. Maybe use melatonin or other medications, but in preschoolers, you really have to use them appropriately with the clinician, and really thinking about them in the context of the entire plan. Importantly, to consider the sensory needs of your child and the parents. Sometimes it's very interesting that sensory needs of a parent can often be correlated with sensory needs of a child. Think about mood disorders. Even in young kids, they may look different. Disorders of arousal, things like ADHD. We may not be diagnosing ADHD in very young children, but you can see certainly arousal disorders early, and we can think about strategies that may be helpful. Think about screening for attachment difficulties, and really, really advocate for appropriate caregiver support. So in the last few minutes here, I think what I'm hoping to do, yeah, these are my final thoughts. I think what I'd really like to do is leave maybe a few minutes for questions and comments from the audience. And I can go back to things in terms of whatever anybody would like. The little picture here is a little guy with FAS who did it for Christmas, and I thought it was super cute, so I put it up there. And I just want to thank everybody for your kind attention, and I'm happy to take questions. If I may, questions that aren't specifically related to an individual child, but maybe more broadly applicable.
Thank you very much for your presentation. I certainly found it very enjoyable and very informative. And so there were some questions coming through on the
Sure.
question and answer.
Oh yeah.
So thank you for this wonderful comprehensive talk. What are the 3 top highest yield interventions you found the most helpful with your most complex, difficult to engage, motivate children and families?
So I know I've said a few times that it really has to be individualized. So what I'm going to say is the first thing to think about isn't so much an intervention, but an assessment tool. And a sleep log is incredibly valuable. There's lots of sleep logs out there. The one I use really has, it has space for 14 days 2 weeks, I really want to look at sleep during weekdays and weekends, because often it's different, patterns are different. And I need to look hour by hour. So it is a lot of work for families. But if you, the sleep log that I use allows me to see things like phase shifts. It allows me to see regularity of patterns. It allows me to see wakefulness, and it allows me to have a conversation with families about what's working, what's not, what's going on in any one particular day. If there's a day where it looks really good, what worked there? If there's a day that looks really challenging, what was going on there? So I will say that that's incredibly important. Once I have that information, then we can talk about how we regularize that day. So now I'm talking about sleep hygiene principles, and we can pull out what are the important sleep hygiene principles to use there. We can also have a conversation about what's the most important part to start with for a family, because what I might think is most important may not be what's most doable for a family. They may say, yeah, I'd really love to push the bedtime back a couple of hours, but it's simply not realistic. So then we have a conversation about what is realistic for you. And then I will say that, in the interest, because everybody always asks me about medications, melatonin can be a really useful adjunct when we're talking about preschoolers, but it's really most usefully applied when I have that sleep log in front of me, when I know what I'm doing with sleep hygiene principles, and then I know how to dose and when to use melatonin. So that's what I'd say is my top 3.
Thank you very much for that. There have been a few people asking if they can have copies of your presentation.
Yeah, I can arrange to make a PDF of that available with Andrew or Edward's help.
Okay, thank you. Thank you for the presentation. Are there any side effects for long-term use of melatonin, especially for the development of a child?
Yeah, I've been using melatonin for well over 20 years. I have not seen any negative side effects. I've seen some temporary differences, sometimes in terms of tolerance. Some families saying it just doesn't seem to work, other families saying it does seem to work. I have had a group of families tell me that they have had their child experience nightmares on melatonin, which honestly isn't something that I see described in the literature, but I have had more than, quite a few families describe that. I tend to think that's probably more unrelated to melatonin and probably more related to individual child sleep patterns. But I do talk about it with families. I have not seen any long-term negative neurodevelopmental impacts, but I also don't push doses as high as some clinics do. I think there is a logical and individual way to use melatonin that really shouldn't just be let's push the dose as high as you can. And sometimes I've seen doses of melatonin over 20 milligrams, and I think that's just a crazy high dose. I would not use doses that high. My dose range for preschoolers probably is in the range of as little as 1 milligram, and frankly, one could go lower. For a preschooler, I don't like going much higher than 6 milligrams.
Thank you very much. My sleep as a parent is totally affected by the wake up of my 3 little ones, or my 3 children with PAE, and experiencing wake ups of all of them. Little sleep. Help. There were a couple of people that had agreed with that. I'm not sure if you're able to give any quick help answers, but it was one of the popular questions.
Absolutely. So one of the things, there is a math of sleep. So if you think of sleep as, think of it in that 24-hour cycle. And sometimes what I'll draw for families is kind of a circle. And, usually when a clinician looks at sleep, they start at bedtime and go forward. That's one way of doing it. The other way of doing it is looking at that sleep log and saying, so how many hours of sleep is an ideal amount of your child? That day that your child, maybe it's just occasionally, your child got a great night's sleep, how many hours is that? And so maybe somebody will tell me, say, 8 hours of sleep, but they're waking at 5 in the morning. If you count backwards from 5 in the morning, and if you assume they were getting a solid 8 hours of sleep, that means they would be falling asleep at 9 o'clock at night. 9 o'clock at night to 5 in the morning, that's 8 hours, right? So that's just pure math. So there's a few assumptions in there, and there's a developmental piece of that. Preschoolers, 8 hours of sleep is probably too short. Probably for kids, say 2 or 3 to 4, you're probably looking more like 10 to 12 hours of sleep and counting backwards. So it's really about playing with when is realistic for them to wake up, balanced with when are they likely to wake up, and then you count backwards and you figure out what bedtime is, and then you come up with a number that's either realistic or not, and you play with it. So it's really kind of about juggling both ends of that, balanced with what a realistic sleep need is. I sometimes get families saying, you know, I want my kid to go to bed at 7 and wake at 7. But if I say, how many hours of sleep did they get? They tell me 9 hours of sleep. That's not realistic. There's 3 hours missing there somewhere. So you have to play around with it. So that would be my first step in doing that, is looking at that. Then I would look at your family and when you like to wake up and when's realistic, and we'd do some playing and we'd work towards a schedule. So that's probably the shortest answer I can give.
And we are closing in on our hour, but I will just see how quickly we can go through. There one other question that was rated more highly. Can you give an example of how the FASD assessment can inform the strategies implemented for sleep?
Sure. So in a multidisciplinary assessment for FASD, we're basically looking at all the different brain domains. So if you know, for example, that your preschooler has a significant language delay, then you're going to know that they're not going to be able to express that they're tired. They may not be able to understand a sleep routine. If you know that they have a lot of sensory processing differences and what those differences are, that can inform the use of sensory calming strategies. If you know that they're cognitively significantly delayed, then in fact you may be using sleep hygiene practices that are more appropriate for an even younger child than their age. If you know, for example, that they have trouble remembering things, then you may feel more patient about implementing a routine that you have to repeat all the time. So those are just a few examples, but that's how we would use it. We would think about what their strengths are, what their areas of weakness are, and how we apply that, in short.
Thank you. And this will be the final question. I apologize for the other questions. They are all really good questions, but unfortunately we're just running out of time. Would like to know about the long-term use of Zopicon on young adults. I see it prescribed a lot.
Yeah, so Zopiclone is not something I prescribe in preschoolers. In under 6-year-olds, never use it. Frankly, Zopiclone to me is something adolescents possibly, but really it's an adult medication. It's not something that I use in kids. So I won't comment on the long-term use of it for adults. I'm a pediatrician.
Okay, thank you.
I maybe I'll add very briefly, I saw a question on timed release melatonin.
Yes.
The short
yes.
answer to the timed release melatonin is I find that it's actually a little bit, you can use it and there may be an individual difference, but I find that it's not quite as effective. People use it with the idea that maybe it will last better throughout the night, but that's assuming a regular release of it. And in fact, melatonin has a peak and then a slide. And so it tends to be less effective with helping kids go to sleep and not as effective in helping them stay asleep. But you know, there could be individual differences, so you can try it.
Thank you very, very much. And thank you everyone for your participation and your questions. We have come to the end of our time for this webinar. It has been so informative. I'm looking forward to sharing this information with people with whom I'm in correspondence or provide presentations to. So just thank you all for participating. The webinars have been, the webinar has been recorded and will be available through CanFASD and the Prevention Institute. I wish you all an excellent rest of the day, and thank you and goodbye.
Thanks so much.